We would discuss how to counsel the parents for the fetus who has a cardiac defect. Now, the counseling should involve that how do you have to break the bad news. That's very, very important because all the family members, those who are involved, should be gathered together, and you don't miss out on anybody who is important in the family. And breaking the news has to be slow, gradual, preferably in vernacular language so that they understand what you are talking about, and don't force and push your ideas and prejudices to the family. Many a time the family is going to ask you that tell me that if you are in my position what you would have done. Please avoid this answer, and go ahead and tell them that I'm sharing with you the medical information and knowledge, and rest is all up to you how to decide with amongst the family. And you must end the talk by asking them have they understood everything or not, and ask them what they have understood, and to your surprise they would have understood just 30% of what you or said, or they might not have understood anything at all. Three kind of responses are expected, what we've seen over a period of time. That one is that they would say that the baby is a God's gift, and I want the baby to continue, pregnancy to continue, whatever the situation may be, whatever the baby's condition is. So they won't terminate the pregnancy, but it's our responsibility to tell them that fine, what are you going to expect, how many surgeries are going to be done, what is the cost, and what they should expect in the future for their child. Second is a person who wants to take a decision based on the information what you have. If the disease is complex or something, they might not like to continue, and in case it's not curable by simple surgery or something, they would like to continue with the pregnancy. There's another category of patients, those who would say, even if the minor abnormality, I don't want the child, and you have to discontinue. So there's pointless discussing details with this patient, but you must tell them that what is the chance of recurrence of a similar event in the future. So now issue is that what are you going to counsel depends upon what the truth you have. Truth is the knowledge, and our knowledge as of today for everybody is limited. Now we have limited knowledge, and whatever we are going to inform the patient is based on this limited knowledge. And you should be humble enough to tell the family that this is the current scenario, and knowledge may not be true in the future, and that's what the limitation is. I am telling you what I know. But it's a good idea to involve more professionals in the fray, because they would be able to guide and have little more information than what you have. And if you all are counseling something, you must involve the professionals. Those can give inputs into your counseling session. The most important aspect of counseling is diagnosis, because everything revolves around the diagnosis. Now, if you have a correct diagnosis, only then you can give a correct counseling. So, you must spend more time on diagnosis. Dr. Osler said the treatment, there are three components of management of a patient: diagnosis, and the diagnosis. So, everything changes with the diagnosis. And let's say this is a patient who had muscular VSD and referred to us, and we did find another abnormality, that is a right-sided aortic arch. Now the whole scenario, the genetic workup, the genotype, everything changes based on the new additional finding. So then there's another patient where it was thought that this has right-sided aortic arch. You can see the aorta going to the right of the trachea. The trachea is marked with white, and then it's going on the right side of the trachea, and it was thought of the right-sided aortic arch, which is a kind of a benign situation. And then we had another a little higher sweep, and we could figure out that the aorta is bifurcating into the two, and this becomes a double aortic arch. So now the whole scenario changes. And how does it change is that you look at this right-sided aortic arch, which is a benign aorta, is just going through the right side. It doesn't produce any symptoms except for some genetic associations. But if it's a double-sided aortic arch, double aortic arch, then you have two arches going across the trachea, and they can compress the trachea, and they can create a problem in the child, and then that means our counseling changes. So we still know that 26% patients of double aortic arch are actually misdiagnosed as a right-sided aortic arch. So it's a good idea to involve a professional even in a minor detected abnormality. It's good to involve a professional who can do a better fetal echo and get more information to whatever we already got. So change in the diagnosis is very important. It changes the outcome, as I showed you. It changes the genotype, so that a geneticist is going to give you a different pattern of sets of tests based on this newer genotype. Usually the the cardiac defects are associated with genetic and extra cardiac abnormalities in over 50% of the patients, and we need to find out that, because our counseling depends upon what is an extra cardiac abnormality along with. And for the genetics, we have plenty of tests available. Those are very expensive in genetic workup, and we don't want to end up with the wrong test and then realize that this is not an appropriate one. So it's a good point and cost effective to ask the geneticist at the first place what the test and what set of investigations would be required in a particular cardiac defect. So what we need to know here is the prenatal outcome. We need to know what is going to happen in the transient period, that when the child is going to be born, what do you expect at that particular moment. Would the child require an urgent pediatric and cardiology interventions? So in case so, then the child has to be delivered in a tertiary care unit, where may not have time to be transported to that place, and we might lose babies during the transport period. So this is very, very important to understand, that is the child having a problem which requires an urgent attention as the child is born. So then the most important question the family and parents would wish to know is that what is the need of the surgery? Is there the baby would need a cardiac surgery? How difficult the surgery would be? What is the cost of the surgery and where it can be done? And would single surgery be enough, or do I need the child would need multiple surgeries? And fine, if the surgery is done, what is the outcome after the surgery, right? So then obviously need to have a chance of recurrence of this fetal cardiac defect in subsequent pregnancies. So let me share with you cardiac defects which are absolutely benign and have no consequences, or a very doubtful consequence. But I have seen many places where people would ask and scare the family that this is a disease which might require to terminate. But these are the diseases which echogenic focus is unnecessarily been overblown. Echogenic focus is a benign situation, occurs in about 6 to 10% of the normal pregnancies, depending upon the ethnic groups, and they are absolutely of no consequence. Now, mild TR is transient, can happen and disappear within a couple of beats or days or months, and it is actually of no consequence. So again, should not be given much importance. And then we have a pericardial fluid which is normal, less than 2 mm of pericardial effusion, or so-called pericardial fluid is normal, and that normal should not be actually considered at all. The subsequent is the outcome which is good. The excellent outcome is in patients with the VSD, with an URSA, except for the genetic association. These tend to have a good outcome and may or may not require surgery. Right-sided aortic arch, as I showed you again, has absolutely good outcome. Generally, it's not consequential. Pericardial effusion, mild, also tends to come and go. We need not worry too much about it. Fair outcome is the diseases or defects which would require single surgery, and after surgery the outcome is very good. And to name a few, DTGA sounds very very dangerous, but single surgery, I would show you that can correct the problem, and then it does not have a bad outcome thereafter. Then you have a double aortic arch, coarctation of aorta. Single surgeries are good enough. Simple DORVs and truncus and non-complex or balanced AVSD again would have no consequence after the surgery, and that's called a fair outcome cardiac defects. A poor outcome cardiac defects are where I think the termination of pregnancy may be considered by the family, and that's one of the single ventricle where we would have only one ventricle to supply both circulations, pulmonary and systemic. Then you have condition like tricuspid atresia, atresia of any valve actually, then again leads to a single ventricle repair. I would show you what is single ventricle repair. And hypoplastic left heart syndrome, I am going to tell you in subsequent slides, require multiple surgeries, and despite surgeries mortality is high, so is the morbidity. What is a double ventricle repair? The double ventricle repair is that you have one systemic ventricle supplying the body, and one the pulmonary circulation ventricle, the right ventricle. So if we have two ventricles, it's an excellent outcome. But issue is that single ventricle repair. The single ventricle repair where you have one ventricle which is supplying the systemic circulation, the inferior vena cava, the venous system from the superior vena cava are connected directly to the pulmonary artery. And by this, what happens, you are missing a ventricle, an atrium, and a valve in between. So in this situation, this is less than ideal, but this is sometimes required in a complex cardiac problems. In this situation, the issue is that there is venous congestion, the life span is not normal, and then the quality of life also there's because of the congestion and other features. So we are looking for a two ventricular repair. That would be an ideal. Let's talk about a couple of disorders to give you an example. I'll take a simple example of a VSD. About 20% of them would like to close before the baby is born. And one thing is very, very important during the transient period when the child is born, the left to right shunt is not torrential at that time, even if the VSD is very large. The reason being the pulmonary vascular resistance is high for 3 weeks, 4 weeks after the child is born. So in this 3-4 weeks period, the left to right shunt is not much. So if the left to right shunt is not much because of the pulmonary hypertension, then the symptoms of heart failure and symptoms of left to right shunt are not present. So we can safely deliver the baby. We have couple of weeks time so that the baby can be shifted to a unit which can take care of the baby. Now the need of surgery, about 80% of the VSDs, particularly the perimembranous, would close by 1 year of the childhood, and then the surgery may not be required. The surgery in a VSD is required in a minority of the patients, and that happens in the VSDs which are malaligned, which are large, very large. They don't tend to close. Another thing is a TGA. Now, the very, very important thing to remember in transposition of great arteries is that the transition period, when the child is born. Now, when child is born, look at the circulation. From the lungs, pulmonary vein, the blood is coming into the left atrium, left ventricle, and back to the lungs through the pulmonary artery because arteries are transposed. Same thing happens with the venous because the blood from the veins come into the right atrium, to the right ventricle, and back to the aorta and systemic. So now this circulation is not serving any purpose of perfusion or getting oxygenation from the lungs. So what we need to do is the child is born, he will be deeply cyanosed unless there is a shunt in between. There needs to be some mixing of the blood somewhere at the ductus level, preferably at the interatrial level or interventricular level. So in case you have a VSD, there's a mixture, that is a kind of a safer proposition. But in case there is no ASD, there's no VSD, this child would have a severe cyanosis as it's born. And what we need to do is that we need to create an ASD or need to do an early surgery in these kind of patients. So these patients can crash, so it should be delivered in a tertiary care unit in all circumstances. So what do we do to create in the parallel circulation? What do we do to create a mixture of these two bloods? Is that to create an ASD? What we do is that we put a balloon and we inflate it in the left atrium. We pull the balloon across the interatrial septum, tearing the fossa ovalis and making an ASD there. And that's the video. You can see the balloon is tugged very quickly from the left atrium to the left ventricle to tear the interatrial septum to create an ASD that provides some time for surgeons to act. Usually in most places people would like to go ahead with the straight surgery, as the surgery is getting more proficient and we can do it early in the neonatal period. So we would like to do a corrective surgery, and the corrective surgery is a switch operation. We switch the arteries from the distal part of we cut the arteries, and when we reconnect the arteries on the distal part of the arteries, so that becomes a normal circulation. The right ventricle supplies the pulmonary arteries, and the left ventricle supplies the aorta. And the problem only happens when we have to transpose the coronary arteries to the respective. This gets us to a point that what are kind of lesions which are important at birth. The left-sided obstructive lesions, and these are the lesions which are kind of duct dependent, and TGA I already told about to you. But then there can be lesions which are of obstructive nature. The obstruction can happen, for example, in a TAPVC. Again, these children can go into a pulmonary edema and require an urgent care when the child is born. So let me discuss these lesions a bit in detail, because they are what we call as a duct dependent lesions. And what are the duct dependent lesions? The first category of duct dependent lesions are left-sided obstructive disorders, like we have a coarctation of aorta, and look at in the coarctation of aorta, the blood coming from the left ventricle aorta is unable to supply perfuse the lower limbs, and the ductus presence is important, because that ductus itself would supply blood, and in case the ductus closes, it would be a catastrophic situation. That the same thing would happen if the aortic arch is interrupted here. So these babies need to be born in the tertiary care unit, because a duct might close any time, usually on the second or third day. And when the duct closes, we need to give a prostaglandins to keep the duct open and then treat the basic disease. So same thing would happen in a patient with a hypoplastic left heart syndrome, where the aorta is small, there is no antegrade flow. The flow in the fetus was from the ductus only, and in this situation, the entire circulation is supported by the right ventricle through pulmonary artery, ductus. You have the coronaries perfused by this, you have the carotids perfused by this, and you have the descending. So this is a duct dependent circulation. If the duct closes, the circulation closes, and this can lead to a mortality. Second set of a similar group of patients where you have a right-sided obstructive lesions rather than the left one. And in this situation, for example, if you have pulmonary atresia or tricuspid atresia, then what happens that the circulation actually from the aorta, it comes to the pulmonary artery to supply. So if the ductus closes, the pulmonary circulation suffers. So we need to keep the ductus patent by stenting the duct or by giving a prostaglandins. Same situation would happen in case you have a severe tricuspid regurgitation, or the RV is bad. It's unable to pump the blood into the right through the pulmonary artery, and it causes a functional pulmonary atresia. Again, the pulmonary circulation would depend upon the retrograde flow from the ductus. Let's discuss a condition which is quite common, that is tetralogy of fellows. And in tetralogy of fellows, as you're aware, there is a VSD, there is an override of an aorta, and there is a pulmonary stenosis. So usually in the transition period, there is no problem or no issue because the pulmonary circulation is maintained by even in a severe pulmonary stenosis. But if the pulmonary stenosis is very severe and it is a kind of a pulmonary atresia, then in that situation, it is a duct dependent circulation and should be the delivery should be done in a tertiary care unit. So now these are the corrective surgery which is done in a very sick patient. We connect a subclavian artery to a pulmonary artery to supply blood to the pulmonary circulation in case the child is very sick, or preferably we go ahead with the direct surgery where we close the VSD, put a patch on the pulmonary artery to open it up because it's already stenotic, and that would actually be a correction for the tetralogy of fellows. Hypoplastic left heart, I mean, it can crash in the transient period. In particular, the patient those who have intact interatrial septum, the patient those who have fossa valis present would do okay. The patient those who have fossa valis absent or the closed fossa valis would do really bad. And thus we can detect in a prenatal ultrasounds, we can see fossa valis restriction, we can see the abnormal flow in the pulmonary veins, and in case you have either of those two, we know that this patient, this fetus is likely to crash in the very first hours of the birth. So they got to be really prepared to manage this patient. But these hypoplastic left heart require multiple surgeries, at least 3, and in between the surgery, the morbidity is very high, and the mortality during the surgery also is high. So this is probably the worst prognosis cardiac disorder what we can have. Double outlet right ventricle is a combination of variable components. So that's why each double outlet right ventricle is not same as the other one. They're all different, and because the surgical outcome here depends upon the position of the VSD, which I'm going to show you in the subsequent slide, relationship with the great arteries, whether there is a and the sub-aortic or sub-pulmonary obstruction, and also if we have a pulmonary stenosis or aortic atresia along with. For example, what do we do in a double outlet right ventricle is that we put a patch on the right side of the aorta, and then we close the VSD. We put small kind of tunnel in the right ventricle, and we redirect aorta into the left ventricle. Initially, it was coming from the right ventricle. Both arteries were coming from the right ventricle. We redirect aorta to the left ventricle, and this is how we do it. We have a small VSD, we enlarge it, and then we put a patch like this. So this becomes sort of a tunnel, and now the left ventricle, which is posterior, would now supply the aorta, and that's a correction in a TOF like DORV. Let's say in case you have a VSD which is placed very distant, or a apical VSD or a muscular VSD, you need to put a large baffle to connect left ventricle, which is lying behind, to the aorta, and this baffle or a tunnel might pass through the tricuspid valve, so that would not be possible. So then this kind of group of patients end up with a single ventricular repair. So outcome with this kind of patients is good. Outcome of patients with the remote VSD is a single ventricular repair, and it's bad. That's how you go to counsel the fetus. So you now understood there are multiple variables in cardiac defect which need to be put together before we make a decision and tell the family what they're going to expect with their fetus. So as I told you, it's important to have more knowledge. You also need to have experience, and the experience of other professionals also need to be put together to counsel the family correctly. But unfortunately, if the experience and the knowledge is limited, and that's what happens, The greater the ignorance, the greater is the dogmatism, and that's by William Osler. Very true statement. We become very dogmatic because of lack of knowledge. I thank you actually to have viewed this thing, and I think this is very very important because many times you need to counsel the families those who have a cardiac defect, and may not be a bad idea to subscribe, so as and when I am going to post, which I am going to post plenty of videos, you would be notified and you'll be able to see. Thanks again, have a good time.